One of the commonest prescriptions which all practicing doctors write every day is oral zinc in acute gastroenteritis because there is a WHO recommendation for that. But many times even senior pediatrician wonder what is the strength of the evidence, how did it all come about, what is the strength in 2021, and really do all children require them all the time when they have a gastroenteritis? We'll try to get an answer to this question. Supplementation of zinc or prescription of zinc is a standard practice in management of acute diarrhea now, but still at times you can have your own problems. Now I'll just give you a case scenario which I saw a few months back. You receive a phone call from a doctor mother whose 18-month-old child is having diarrhea for 2 days. Child at 10 to 12 watery stools was vomiting on day 1 with moderate to severe dehydration and was treated for 6 hours with IV fluids and sent home on ORS and 20 milligram of zinc for 14 days. Child takes a vegetarian diet, weight is on the 50th centile, height on the 75th centile, and child is fully immunized but has not taken rotavirus vaccine. Now she comes to you with the second day she's slightly better, but still has 5 loose watery stool, a moderate amount, but what is troubling her is the vomiting. She has 2 vomiting. Child is active and passing urine well with tears while crying, and the mother says the child is vomiting after taking oral zinc and is not able to tolerate ORS because of that. Child has taken an aversion to anything oral and is vomiting. She feels the child is vomiting because of the ORS, also because of the taste of zinc. Now, what are the options available to you in such a scenario? Something which you may see very often. 1, you stop the zinc. 2, decrease the zinc dose to 5 milligram OD. 3, give ondansetron and make sure you continue zinc for 14 days. If needed, give IV fluids because that's a standard treatment. Zinc has got evidence in treatment of acute gastroenteritis and you will insist on it. Well, I think the journey started in 2004 when the United Nations UNICEF brought about a clinical management of acute diarrhea, a joint statement. Well, for this little kid, I'm sure you would agree with me, we must do all the best for him. Now, zinc supplementation, they said the zinc supplementation reduces severity of diarrhea and duration of diarrhea, and zinc supplements prevent subsequent episodes of diarrhea also. Later on, they said it prevents subsequent episode of pneumonia also. Now, therefore, the WHO and UNICEF therefore recommended daily 20 milligram zinc supplements for 10 to 14 days for children with acute diarrhea and 10 milligram for infants under 6 months old to curtail the severity of the episode and prevent further occurrence in the ensuing 2 to 3 months. Well, the world body must have based their on solid publications, evidence. One of them is the therapeutic effects of oral zinc in acute and persistent diarrhea in children in developing countries. Pooled analysis of randomized controlled trials, published in 2000 in the American Journal of Clinical Nutrition. Now they came to the conclusion that zinc supplement reduces the duration and severity of acute and persistent diarrhea. There were many publications like this, meta-analysis, etc., on which this oral supplementation was supported by UNICEF. Come 2010, there seemed to be more exciting evidence. Zinc for the treatment of diarrhea, effect on diarrhea, morbidity and mortality, incidence of future episodes. This is the International Journal of Epidemiology in 2010. It said the evidence supporting the zinc for the treatment of diarrhea include 12 high quality randomized efficacy and effectiveness trials with demonstrated reduction in severe morbidity and mortality. Very, very high evidence in zinc. Zinc for the treatment reduces diarrhea mortality by 23%. And when given as diarrhea treatment, zinc supplementation not only decreases the severity of the initial episode, but may prevent future diarrheal episodes in 2 to 3 months' time following supplementation. Very solid evidence for zinc. Note, in 2010, there was solid evidence for reducing the diarrhea mortality by 23%. Of course, it must be in the population in which it's studied. But they soon qualified the statement by telling that because this estimated 23% reduction in mortality was not derived solely from mortality studied, it has some limitations. They qualified that statement. That was a sweeping statement to make that 23% reduction in mortality. They calculated by some indirect method applying the Child Health Epidemiology Reference Group systemic guidelines, some other, not a direct calculation of the mortality which was not practicable. The additional limitation was that the inability to completely separate the effect of zinc on mortality from the effect of ORS on large-scale effectiveness trials. Because this some will challenge the notion that providing an estimate for the effect on mortality based on anything but randomized controlled trials with mortality as an outcome should not be done. However, because of the strength of evidence supporting zinc for diarrhea treatment, RCTs are no longer ethical. Thus, the ideal data will likely not be available. What they say is that they cannot separate whether 100% the mortality decrease is due to zinc itself or is partially contributed by ORS also, because it's no longer ethical to have a placebo in which you don't give zinc or ORS, either of them. This is the best evidence one can get, but they're quite sure of the evidence. Come 2015, in a publication, 6 supplements in acute diarrhea and IJP. The present results show that zinc supplements can decrease the mean duration of diarrhea by 14.47 hours compared to control group. But they go on to say the authors cannot draw any meaningful conclusion yet, as many other factors like nutrition status, age group, zinc serum levels can influence the result, and heterogeneity among the study subjects in published reports was obviously high. Now, when the enthusiasm was very high in 2010, the 2015 it seems to be waning. They seem to say that the studies in which the meta-analysis has been done has been quite heterogeneous, and therefore they cannot arrive at a definite conclusion and cannot draw any meaningful conclusion. That's what they state. And they finish off with the usual jargon. In order to find the most cost-effective way to treat acute diarrhea, most studies need to be conducted on a more homogeneous pool of subjects, taking all relevant factors into consideration. Note there's no mention of decrease in mortality. Note there's no mention of less incidence of second attack of diarrhea, etc. Therefore, the enthusiasm seems to be waning. What do we do now? Now we are getting, therefore, we look at the Cochrane Database Systemic Review 2016. What more? It can't get better than this. Let's now look what does it say. In 2016, I'm sorry, not 2006, 2016, randomized controlled trials that compared oral zinc supplement with placebo in children aged 1 month to 5 years with acute or persistent diarrhea, including dysentery, was done. And 33 trials that included 10,841 children met the inclusion criteria. Most included trials from Asian countries that were at high risk for zinc deficiency. And now you might be excited to look at the results. Now, what does it say? It says that there is currently not enough evidence from well-conducted trials to be able to say whether zinc supplementation during acute diarrhea reduces the number of deaths or the number of children hospitalized. Very low certainty of evidence. This is a bombshell, is it not? In 2010, they said meta-analysis showed a decrease in the mortality by 23%. Now they say there's no evidence. Add on to it, in children greater than 6 months of age, zinc supplements may, note this, shorten the duration of diarrhea by around half a day, 12 hours only. Low certainty of evidence. Therefore, so evidence has also come down and probably reduces the number of children whose diarrhea persists until day 7. Moderate certainty of evidence. Probably and may. Note it down. In children with signs of moderate malnutrition, the effect appears greater, reducing the duration of diarrhea by around a half. High certainty of evidence. If you little sit back and think and just not talk of evidence, definitely zinc is a nutrient. Whenever it is deficient, when you supply it, it will have benefit. When you don't have deficiency, it won't have benefit. Anyway, whatever it is, the enthusiasm in 2016 by the Cochrane systemic review, the evidence has gone down considerably. The enthusiasm has gone down considerably. The Cochrane review goes on to put another bombshell. In children less than 6 months of age, the available evidence suggests zinc supplementation may have no impact on the duration of diarrhea, low certainty evidence, and may increase the proportion of children whose diarrhea persists until day 7, low certainty evidence. Don't forget that WHO and UNICEF even now, I think to my knowledge, advises 10 milligram zinc for all children below 6 months. Therefore, if you look at the applicability of the evidence, the Cochrane review showed zinc overall reduced the duration of acute diarrhea. They do agree to it. However, most trials were conducted in population with moderate to high risk zinc deficiency, like Asia, Africa, children over 6 months of age with some degree of malnutrition. This was the study population in most of the studies. The transferability of these studies to other countries is therefore likely to depend on the local risk of zinc deficiency and other population characteristics such as degree of malnutrition and breastfeeding habits. Therefore, in populations in which most of the children are well nourished, the results may not be applicable according to them. The study goes on to say the few trials conducted in population at low risk for zinc deficiency, that is namely well-nourished children, in countries and continents where zinc deficiency is uncommon, and like Europe and Australia overall, show no benefit of zinc supplementation in diarrhea. More trials were conducted in hospitals where participants are more likely to adhere to the intervention. You must know that our action is in the community. We are giving zinc to the whole population, but most of the studies were conducted or were hospital-based. But some community trials also showed a benefit of zinc, which suggests that zinc could be used. It's not a very could be used both at hospital and community level. It would have been better if we had more community-based studies because we're using it in a very large scale in the community. Coming to vomiting, the point of interest in the case I presented, the observed increase in vomiting was consistent across trials in our age groups, with one large trial reporting that vomiting was limited to one episode with most children and mainly occurring within 10 minutes of administration. The vomiting is well documented, but it's not persistent vomiting is not very common. Zinc has a metallic aftertaste, and the development of more palatable formulation may minimize this adverse effect. Many of us pediatricians, when we write zinc left, right, and center for all cases of acute diarrhea, we often think in whether there's really required for giving this medicine for 14 days. What's the strength of the quality of evidence? Now, in general, the Cochrane review says the methodological quality of trials, including the review, was good, but the evidence for benefits on diarrhea duration in children aged greater than 6 months is low to moderate certainty. Note here, they're not even mentioning about mortality. That 23% mortality is forgotten. This implies that they are only talking of duration of diarrhea. This implies that we can have some confidence in the result, but further research may alter the estimates of benefit and harm. Therefore, down the lane, I am sure that zinc may be thrown out of the therapeutic armamentarium, maybe. Now, the main reason to downgrade were the quality of trials and inconsistency of the result. They say the heterogeneity of the studies was a very important point. Therefore, they were not very happy with the quality of trials and inconsistency of the results. At the end of the day, the Cochrane review in children over 6 months of age, which I have been discussing for some time now, support the current WHO UNICEF policy to give children with diarrhea, while currently there are no evidence for a randomized controlled trial to provide children younger than 6 months. Therefore, above 6 months, they are supporting. Below 6 months, they are not supporting. Remember, of all the statements they have made, of the reservations they have done, in spite of the downgrading of the evidence, in spite of the fact that they don't support that there's any evidence for decrease in mortality, they still continue to support to give zinc over 6 months of age for all children with diarrhea. Therefore, we can continue that practice. So what's the implications in practice? Not to forget, not to lose the plot. In areas where diarrhea is an important cause of childhood mortality and the prevalence of zinc deficiency or mild moderate malnutrition is high, zinc may be of benefit in children with diarrhea aged 6 months or more. This is the final implication in our practice. Already the decrease in the evidence for supporting zinc has repercussions all over the world in practice. The Canadian family physician in 2013 has made a categorical statement. Although the World Health Organization recommends a daily dose of zinc for 10 to 14 days to manage acute diarrhea, Canadian children who eat a regular diet do not need such supplementation. The question arises, therefore, if you are in a developing country like India and you are seeing patients in your practice who are well nourished, do they really require zinc? Do they go with the malnourished children in the community, or you have to compare them to the well-nourished children in the Western countries? Now, if you look at the up-to-date, which often reflects the practice in America, they suggest, this is something article written in 2017, we do not suggest iron zinc in the management of acute gastroenteritis in children in resource-rich countries, where zinc deficiency is rare and no benefit from zinc is expected. Therefore, in USA also, this practice is not seen to be there from what I read from up-to-date. Now, to this article from New England Journal, lower dose of zinc in childhood diarrhea, randomized multicentric trial. Some relevance to the case in discussion, which I put up before you. After all, there's no kick if you don't quote at least one evidence from New England Journal. Now, they randomly assigned 4,500 children in India and Tanzania for this study. In this large multicentric clinical trial, lower doses of zinc, 5 to 10 milligram daily for 14 days, were non-inferior to the standard dose of zinc 20 milligram in terms of duration of diarrhea and mean number of stools in children. Therefore, the 20 milligram was not required, 5 or 10 milligram was enough, they say. Both 5 milligram and 10 milligram were superior to 20 milligram dose with respect to vomiting. So this is the clinical significance. If you find a child with vomiting, decrease the dose to 5 or 10 milligram, you may have the same efficacy and with less of vomiting. And vomiting is often a part of acute diarrhea syndrome. Meta-analysis have shown 50% higher risk of vomiting in children taking zinc supplements. Therefore, this has some relevance to the case we have for discussion. Now, just to give you an idea why infants and children are prone for zinc deficiency. If you look at the RDA, which is the recommended dietary allowance, which makes if you take that amount, 97% of that age group will get the nutrient required. Now, 7 to 12 months is about 3. In infants, is around 2 to 3 milligram, and per deciliter, 2 to 3 milligram per day. Now, in children, 1 to 3 and 4 to 8 years, it's about 3 and 5. Therefore, it hovers around below 5. And older children, 8, 11, 8, 9. Therefore, it is slightly above slightly above what the infants and children require. So if you remember, around about 5 for children and adolescents 10, it might be fine. But let's look at some of the contents of the food items, how much zinc they contain. Now, if you look at oysters, it is a very good amount. In 84 grams, 6 medium-sized oysters contain 80 milligram, very high. Liver and hamburger are good enough. And breakfast cereals is a trade name for an oats cereal in the United States. 1 cup will give 3.7 milligram. Good enough. It might be enough for a child for a day, isn't it? For children, 3 milligram would be good enough if you give one breakfast cereal 1 cup. But if you look at vegetarian, sunflower seeds, if you look down, it will be very much less. Even white meat, 3.5 ounce or 100 grams gives only 1 milligram. Now, milk is supposed to be a good content for everything, but even if you drink 1 cup, it only gives 0.9 milligram. Therefore, it's not a good source of zinc at all. and rice, half a cup gives 0.6. Egg, if you think egg gives a large egg, gives only 0.5 milligram. White rice, 2/3 of a cup gives 0.4 milligram. For vegetarians especially, they are prone for zinc deficiency. Therefore, if you look at it in a different way, the primary dietary sources of zinc include animal products such as meat, seafood, and milk. They are adding milk. I don't know how they are saying milk doesn't seem to contain enough food. Therefore, animal products are the which contain zinc in adequate quantity. Ready-to-eat cereals contain great amount of zinc consumed from plant products. Therefore, if you the breakfast cereals actually are very good, they contain adequate zinc. Sufficient dietary zincs are available typically in mixed diet, but lacto-ovo vegetarians need more milk, eggs, grains, legumes, nuts, and seeds to achieve adequate levels. Therefore, if I'm a vegetarian like me, I will have to take more of nuts and seeds and legumes. I mean, in a considerable number. Even eggs, we noted, does not contain enough of zinc, much of zinc. Therefore, they will have to take more in number to get adequate zinc. That's why our population is prone for zinc deficiency. The depletion of zinc is caused by both by inadequate zinc intake and the binding of the ingestion zinc to fiber and phytates in unleavened bread Therefore, what happens is not only the decreased intake, but the zinc also gets bound to fiber and phytates. Now, this is the reason. If you look at American Academy of Pediatrics, the first weaning food they now advise is ground red meat. One of the reasons is it contains iron and also it contains zinc. In particular, use meat and liver as a first food for infants might provide a practical solution for infants in developing countries. It's not a practical at all. I don't think our parents will take to this easy. Therefore, zinc, we are prone for deficiency. Even if you are a healthy, well-grown child, especially if you are a vegetarian. This is the case which I presented. We are coming to the close and the case which I presented at the beginning. This is a moderately sick child because he requires IV fluids, and he was correctly managed, sent home with ORS and zinc, etc. Certain things should have caught your attention. The vegetarian diet he is more prone for zinc deficiency. But what is good is growth seems to be okay, and something could be of concern is he has not taken rotavirus vaccine. Therefore, he might be more prone for more severe diarrhea. That should be kept in the back of the mind for whatever decisions we make. Now, if you look on the second day when he came to you, actually, he is well hydrated, but still having a problem of vomiting and still continuing to have loose stool. Therefore, he can deteriorate, but seems to be improving. Therefore, that's the situation. Therefore, what's the solution available to you? One is to stop zinc. And second is to decrease the zinc to 5 milligram OD, as a New England Journal says it will decrease vomiting. Or say that, look, I am going to follow the WHO guidelines to the hilt, and I would give him ondansetron and make sure that the vomiting stops and persist with the zinc for 14 days, and even give IV fluids if needed. For which of the choices would you go? In this stage, all of us pride in practicing evidence-based medicine, and that involves the best available research evidence, taking also, of course, contributed by clinical expertise and patient values and preferences also. This is very important. Patient values and preferences have to be taken into account. Therefore, if you look at the best available evidence, the green is what I say points towards giving zinc. Therefore, zinc decreases the duration of diarrhea. Therefore, that is a point in favor of giving zinc. No evidence it decreases mortality. No evidence of benefit in well-nourished children. Therefore, this is a well-nourished child. Therefore, these 2 points might say you may consider for not continuing with zinc. And the other point is zinc deficiency is common in vegetarians. Therefore, that's a point in favor of giving zinc. And this child is not immunized against rotavirus, and therefore he might have a more severe diarrhea, and that might again point you to giving zinc. And the other point in favor of giving zinc is that normally when you give zinc, the vomiting lasts only a day or two, only once. And then if you continue zinc, normally the vomiting does not persist. But as they often say, children don't read the textbook or the guidelines. They might look directly opposite to what is written there. Here the mother is worried that he continues to vomit, and it is even affecting his ORS intake. Now look, you would also take into my what is your clinical experience. I have been practicing for nearly 40 years in pediatrics, and luckily for me, touch wood, I have had no mortality in children whom I have seen in my private practice about diarrhea, because I closely follow them up. And I feel that the population which the zinc deficiency has changed mortality, if at all, or morbidity, is not the population which we treat in private practice. That may be a biased opinion. I'm telling you very frankly. Then, of course, you take the patient's values here. The mother is concerned about vomiting, and she's almost sure it is due to zinc. Otherwise, she wouldn't trouble you with a telephonic talk like that. Therefore, what is the verdict? You take all these into consideration. And the main consideration which comes to is, yes, zinc is effective, but the strength of the evidence is going down. The enthusiasm for giving zinc is going down. Western countries are no longer giving. I take it all into consideration. My verdict may not be a verdict. I would give the mother the choice of decreasing the dose to 5 milligram per OD. And I don't think she will take it because she's very concerned. I will reassure her there's nothing wrong in stopping zinc, at least temporarily. I would prefer to stop zinc and restart after 5 days on low dose, 5 milligram OD for 14 days. That would be what I would take a decision based on everything I have discussed with you. With this, we come to the end of the presentation, and thank you for listening to me so long. Some people have told me that it's difficult. I would like to hear from you, especially if you have difference of opinion about anything which I have stated, especially if you don't agree to some of my opinions which I have given. Now, some people have written to me telling that they have problems in contacting me. Therefore, for the first time, I'm giving you my email address and my mobile number. In case you want to contact me, you're free to contact me at any time. And I'm Dr. A. Padmanabhan, and I have my other posts are in this YouTube site, and I also used to blog on wordprocess.com. Thank you, and goodbye till we meet again.